You buried the implants, you let them sleep, then you came back and you uncovered them, and you converted the temporary. So they come back and they're in the temporary. This is what we're going to do, start the process of converting into the final. So for those that have done all fours, you can kind of compare this to your workflow and how you restore them with this recommended approach. Ideally, slightly convex, the restoration is slightly convex, and the tissue is slightly concave. So ideally, you get this little well of the tissue, which is where your prosthetic was actually rounded and kind of pressing into the tissue. You think about like if you were to run a piece of floss underneath the entire arch, is your floss contacting the entire arch all the way around? That's kind of the idea of how to make a really cleansable restoration. One of the ways you can do this is actually designing your temporary convex, and when you're screwing it on and letting the tissue heal around that, the tissue is going to heal concave because you designed your temporary to be convex and you shaped your tissue with your temporary. So it's really nice when they come in and it's already concave tissue and the convex temporary. You don't have to worry about what your final restoration is going to be. Does anyone have any questions about that?
I have a question. Just, with multi-unit abutments, like a locator abutment, you have to measure your tissue height to get the right height of your locator. Are multi-units like this at all? Like if your implant was super deep on one of these, would your whole entire multi be down under the tissue, and how do you troubleshoot that?
Yeah, that's a good question. So, yeah, there are a handful of heights. So like the straights could be as short as 1 millimeter and as long as like 4 millimeters. And then the angles are usually like 2.5 to 4.5 millimeters in height. And so,
all right.
So here's kind of how I like to, I wish I had a diagram of this, but.
So it's similar to a locator then, you have different heights.
You have different heights, yep. And ideally this is all kind of pre-planned. So let me paint like a perfect picture. Here's your implant platform. And you have a 2 millimeter high multi-unit abutment. And you have your implant 1 millimeter below the crest. So here's your implant. 1 millimeter up is your bone crest. Another millimeter up is the height of your multi-unit platform. And another millimeter up is like your tissue. So does everyone kind of follow that? In a perfect world, your multi-unit platform is like just barely under the tissue. And your implant is like 1 millimeter under the bone, or whatever you prefer to, however deep you prefer to put your implants. But I like having a shorter multi-unit so that you're just slightly below the tissue. Because anytime, here you can see this is just maybe a hair above right here. And so that's just an area where it's hard to make a restoration and stuff might kind of hang around that area. Does that make sense? So that perfect seal would be your multi-platform just below the tissue, and then the prosthetic kind of emerging from that. And you're getting close here, but that's how you'd strive for it. So yeah, there's heights. I think the best way is having your multi-unit platform be like just above your bone, like 1 millimeter above the bone. And then that's going to ensure that it's just a little sub G, which is nice. Everyone kind of follow that? So yeah, there's different heights. The angled ones they always take up more space too. You can't get like a 1 millimeter angle. It's usually a minimum of like 2 to 2.5 for the angle ones. They're just more space because you got to make that turn.
Nice.
Yeah. So set your tissue up with your temporary. So let's just say you weren't doing immediate load and you buried your implants and you're coming in for the day of uncovery. One method might be to do a full arch flap, full keratinized tissue flap, pull it all back, put your multis on, have your temporary be kind of rounded, convex, and just have your tissue lay up against that, and it's going to invaginate in and grow in and granulate underneath, and you've kind of shaped that tissue almost like a concave tissue profile. And you're gonna have less tissue or food getting underneath your prosthetic because it's just got that nice seal, that nice rounded underside in that seal. So if you can create that, it's ideal, and you'd like to see something like this. Okay, so what you're going to do is, we've taken off the temporary. We've checked our torque. All the multis are good. They're all solid in there. No issues. We're going to put the temporary back on, but instead of using the teeny little screws, we're going to use long lab screws. So you got to get some of these long lab screws that are 4 multi-units, but they're long. They stick out. They stick out of the temporaries. The temporaries in there are going to be hanging way out past the teeth. And then we're going to perform an open tray impression of that temporary. And these are called mirror trays. You can get them, from wherever. I think they're even on Amazon. And you get a box of them, like 3 upper, 3 lower, for small, medium, large. They're a little bit spendy, but you can reuse these guys. Just cold sterile them. I've reused them before. And you can get a few uses out of them because that cellophane will hold up for a few impressions. And then your assistant's going to start filling up that mirror tray with heavy body, and you're going to be squirting light body up and under and around your temporary, just like you saw from LaToya in the video. She's holding the retractors out, getting the tissue out of the way. I'm injecting light body, and that way the light body's getting underneath the prosthetic if there is space. If there's not space, then great, you did a nice job, but usually there's a little space, and you want to inject material under there to capture that. And then you're going to seat the impression, let it set up, and then you're going to unscrew and just do an open tray impression. You're going to unscrew the 4 long lab screws, and you're going to pull it out. And when you pull it off, your temporary is going to come off inside the impression. You're going to have now a verified impression, or a picked up. It's all splinted together. You're not looting all the impression copings together. You're just using their temporary as a pickup. Then you're going to place analogs inside, just like your open tray impression. You're going to place the analogs inside of that, and they're going to be sticking down. And now you're going to lubricate this. You can use a little Vaseline just to kind of lubricate it if you want, because what you're going to do is you're going to pour a soft tissue moulage. Because if we just pour this all with stone and we have a master cast with just stone, it's hard to really for the labs to work on. That soft tissue moulage is really valuable because they can peel that out and look at the platform, and they can have some tissue to kind of build up against. So I just use light body as the soft tissue moulage. So what you're going to do is,
that much or less?
So here's the soft tissue moulage right here. So after you put a little Vaseline on here, take your light body and just run it all the way around just the implants as if you're creating that soft tissue moulage on the cast. Don't run it up. You don't want it running way up high on the analogs because you want those analogs buried in stone. You want them encased in stone. So you just want a light layer all the way across. And you're going to let that light body set up. Then so you add the analogs, you place your separator, Vaseline, you're going to do your light body moulage. Then you're going to pour the impression. So you're going to just do a standard pour up with stone. Then you're going to pull off the entire complex. You're going to loosen the 4 screws, pull off the complex, and this is what you're going to end up with. So this is the stone master cast with that light body as the gingival portion. And this is great because you can just peel that out and look at the platform, and then they can kind of press against that like it was gingiva. So that's the temp that's on the master cast. When we take it off, here it is. So anybody lost yet? Cool. So
can I just say one thing, Matt?
Yeah.
I almost had an emergency in my office on a little 5-foot lady doing her upper PMR. And I didn't have a custom tray made. I just had a regular tray.
stock tray.
We put in a stock. I did all the light body everywhere, put it in right. And I cut the holes and I could see everything. But it set up so fast and it was down the back of her throat. And I couldn't you can't pull it out
right,
at that point.
right.
The only choice is to get in there and unscrew those screws.
Yep.
And she was almost puking on me.
Oh, that's bad, yeah.
She's 5'0" in this little teeny mouth. I could barely get my drivers up in there in her mouth. It was almost an emergency situation. Like I was almost going to take a 15 blade and then just slice off that piece of the back or something.
Yeah.
She was gagging. I couldn't pull it out. I tried yanking on it. I couldn't get it out of her mouth. she was almost panicking. I was sweating, and I slowly was able to unscrew those suckers and get them out. But dude, it was a panic moment. I was dripping, coated in sweat within like 3 minutes. And the patient almost vomited everywhere. Anyway, so
Yeah.
my own recommendation is use your mirror tray, you said, or make yourself a custom tray.
Absolutely.
It fits up snug against
That's
the
really
roof of
good.
your
Yeah,
mouth.
that's really good feedback.
Because it almost turned into an absolute nightmare scenario.
Because it's hard to get those things off sometimes.
It's
and
way hard. It's harder than it looks.
You need plenty of time to do it. Yeah, you don't want to be rushed. Yeah, because those mirror trays have a big posterior stop back there.
Yeah, I've noticed.
So that's
I learned the hard way.
so yes. All right, good. Mirror trays or custom trays only. Cool.
Custom tray works sweet, by the way.
Yeah.
You design it yourself.
Yeah, absolutely. Okay, so let's. So now I want to talk about. Now we've got, this is kind of the analog world, but this is where we want to start to transition into the digital world, because this is digital dentistry. We want to talk about how we can get all this stuff into the digital world and restore this patient digitally. So up until this point, we made a master cast in the analog world because I still like having and holding a master cast in this process. And I think it's really good practice to understand all the workflow. So make a master cast. It's really not that hard to do. Now that we have this, what do we do? So we need to get a few scans, and this is where I'm going to kind of break this all down. But scan and put it in the mouth and send patient home. Okay, so typically you would put this back in the mouth and scan the patient with the temporary in the mouth. But there's something that I want you guys to get here. So you got your master cast, the patient's sitting in the chair. The temporary is on the master cast. It's still on the master cast. I want you guys to scan the temporary on the master cast. You can use an iTero, that's fine. You don't need to use a desktop scanner, or you can use an intraoral scanner, whichever one you're using. But scan that temporary on the master cast, catching some of this cast in the scan. So that's really important because these landmarks down in here, you want to capture in your scan. So you're going to have to turn off your AI cleanup if you're using an iTero. But keep it on there, walk it over to the scanner, scan the temporary on the cast. Super important. Because if you forget to do that and you go put it back in the mouth, you lost that chance to get that. So before you deliver to the patient, scan it on the stone. And I'll explain why in a second once we get here into the digital world.